All right, it is 8:30, so we're going to go ahead and get started here. So thank you everybody for joining for today's ultrasound case series presentation. This is going to be the last one of the fellows portion for this academic year, but we'll keep going next month, but restarting with our attendings in July. So first, as usual, just going to put a plug in for the AMSSM Library of Sports Ultrasound Pathology. So again, this is a collection of sports ultrasound pathologies that get housed on the AMSSM website. These are good things that you can add to your CV. If you have questions about that, you can get to the library link through the QR code or email the emails at the top of this slide. Currently, this month, they are looking for more wrist pathology cases. So this can be a lot of different pathologies they're looking for. Just a few examples: wrist joint effusion for CMC OA, extensor tenosynovitis. They're looking for really a lot of different things for the wrist pathology. So that's listed on most recent AMSSM email blast. So if you want to see what pathologies they're looking for the wrist, you can head to that email and find that. Secondly, another plug for our ultrasound case series catalog. So again, this is a document you can get to through this QR code that essentially houses all of our links to all of our YouTube videos and breaks them down by body region and pathology. So it's a little easier to get to and from these YouTube videos. So great resource where you can access things if you're looking for something specifically. So recommend going to that if you're trying to get more out of our ultrasound case series. So without further ado, I'll introduce our speaker for today. So Colton Schwarz is going to be talking on pelvic apophyseal avulsion fracture. Colton is currently a primary care sports medicine fellow at Nationwide Children's Hospital in Columbus. He grew up in Wisconsin, where he obtained his undergraduate degree at the University of Wisconsin-Madison prior to moving to Kansas City for medical school at the University of Kansas, and he did pediatric residency at Children's Mercy Hospital. Colton has decided to join Nationwide Children's as a faculty member this fall. So I will hand it over to Colton, where he is going to be presenting on pelvic apophyseal avulsion fracture.
All right, let's get into it. So I'm going to share the case on pelvic apophyseal avulsion fracture. I have no disclosures today. Before I start, just want to give a shout out to Dr. Drew Dewerson for helping me put together these slides and giving some good constructive feedback. And then also shout out to him and Dr. John Napolitano and Dr. Whistler St. Ville for their role in giving me a good formalized ultrasound education this fellowship year. So our objectives today, we're going to review a case of pelvic apophyseal avulsion fracture. And then we're going to work on describing the ultrasound protocol for the anterior hip, giving unique considerations for the skeletally immature athlete. We're going to identify the sonographic findings of an apophyseal avulsion. And then lastly, we'll complete a diagnostic ultrasound report for the anterior hip. So with our case, we have a 16-year-old male soccer player who injured his hip a week ago. He was playing in a soccer game, went to kick a ball, felt a pop and immediate pain. He was able to bear weight after the injury, but he has not been able to return back to sport. He tried to run a few times and it didn't go so well. He initially had some localized swelling along his hip that has since resolved. No bruising, no prior hip injuries, and no history of hip pain up until this point in time. So on exam, you have a well-appearing adolescent male. He has a normal gait. On inspection, there's no swelling, bruising, erythema. On palpation, he does have point tenderness along the ASIS and proximal hip flexor tendons. Range of motion testing is full throughout. However, he does have pain along the anterior hip at terminal extension. Strength testing is also full throughout, although he has a lot of pain with resisted flexion and more mild pain with resisted external rotation and abduction. With special testing, his Faber and Fader precipitates some pain along the ASIS, and he's neurovascularly intact. All right, so we initially got some radiographs for this patient. We got AP and frog-leg views of the pelvis and bilateral hips. With these radiographs, you can see an open iliac crest apophysis. However, it's really difficult to appreciate any radiographic findings of an open ASIS or AIIS apophysis. The femoral physes look like they're trying to close if they have not fully closed already. The femoral head is well seated in the acetabulum on that frog leg view to the right. However, you can appreciate bilateral cam deformities, most notable along that right side on the frog leg view. And so with this, let's get into our AMSSM recommended ultrasound scanning protocol for the anterior hip. And so we'll start out taking a look at the femoral head and neck junction with the capsule and anterior synovial recess, taking a look at the hip joint itself, which will include the labrum. We'll briefly take a look at the neurovascular structures medially, and then we'll go over to the iliopsoas tendon, assessing it for bursitis or any pathology. And then we'll hit up the sartorius, TFL, rectus femoris tendons. And then dynamic scanning for snapping hip, we actually will do in this patient. And then under the optional section, you'll see the dynamic assessment for hip impingement, which we decided to do for our patient given his anterior hip pain and bilateral cam deformities on the radiographs that we got. Additionally, I'll say that when you're scanning the anterior hip in a skeletally immature patient, it's important to expand your exam beyond just the muscles and tendons. You should evaluate the nearby apophyses, particularly the ASIS, AIIS, and lesser troch apophyses. These sites are commonly overlooked, but they're really key when evaluating for apophyseal injuries. You can see some additional apophyses you can look at depending on the clinical scenario. The iliac crest, that's getting more into the anterolateral hip, and then the pubic symphysis, that's getting more into the medial hip. But today we'll walk through our standard anterior hip protocol, keeping those apophyses in mind. And so the setup for this anterior hip exam, we're going to have the patient resting supine. The transducer selection will depend on body habitus. I would argue for kids who are thinner, everything can typically be done with a high-frequency linear transducer. However, in a larger body habitus, the femoral head and neck junction, the joint, and the labrum may best be seen with a curvilinear probe. Additionally, that curvilinear probe is what we typically use for ultrasound-guided hip joint injections. I'll say that this tends to be a more sensitive exam, especially for kids. So just making sure that you're being considerate and getting them as comfortable and covered as possible. One method you could do is getting them into a gown and using some towels to cover their genitals or any other skin surface not needed for scanning. Other people like to use paper shorts and cut them up, which is totally fine too. All right, so we're going to start off with a view of the femoral head and neck junction. You can place the hip in slight abduction and external rotation to best visualize the joint capsule. There are a couple ways to get into this position for this image, but the method I learned is starting with that transducer in the short axis along the femur and moving it proximally until you see flattening, and that flattening is indicative of the greater and lesser troch. When you see this, you can rotate your transducer into an an oblique sagittal plane along the head and neck junction and slightly tilt that transducer cephalad. You'll then be able to see the overlying hyperechoic anterior joint capsule with a hypoechoic anterior joint recess in between the capsule and the femur, which we see in our ultrasound image here. The joint recess and capsule can be assessed for a presence of an effusion, synovial hypertrophy, or synovitis. And as we know, that anterior joint capsule is composed of two layers, the anterior and posterior layer, that measure up to 2 to 3 millimeters in thickness each. It is considered normal to have an absence of fluid separating those layers. However, it can be considered physiologic to have up to 2 millimeters of interlayer fluid there, which would be hypoechoic in appearance. Textbooks will mention the importance of evaluating the capsule while keeping the femoral neck in a perpendicular orientation, as it will prevent the capsule from appearing falsely hypoechoic, which can occur if you take a look at it in more of an oblique orientation. Additionally, that capsule is normally flat or concave in appearance, and a convex contour could indicate an effusion. However, you should make sure that that hip isn't in internal rotation, as that also could give a convex appearance. You can measure the total thickness of the capsule fairly easily when there's no fluid between the two capsule layers, as we see in our patient here. Normal thickness is around 6 millimeters or less. You can also measure the anterior joint recess, and a difference in joint recess thickness over 2 millimeters is suggestive of an effusion or inflammation. Our patient here has a normal hyperechoic concave appearance of the joint capsule with the femoral neck in a near perpendicular orientation. The capsule thickness and anterior joint recess are within normal limits. You can see the overlying musculature that includes the iliacus, just anterior to the capsule with the rectus and the sartorius superficially. And then lastly, I'll just mention you can do a sweep of the proximal femur, femoral neck, and head to look for any cortical irregularity that's suggestive of pathology. In our patient, you can see some subtle cortical irregularity along the distal portion of the femoral head, which is indicative of the physis. Yeah, all right. So to take a look at the hip joint, we like to start a little bit more laterally along the hip, above the greater troch and underneath the ASIS. So you can slide your probe, our transducer laterally around the thigh into a more coronal oblique plane. With our patient, you can see the hyperechoic triangular appearance of the anterior labrum, which extends from the margins of the acetabulum, and this is normal in appearance. You can look for the presence of hypoechoic clefts, heterogeneous echogenicity, paralabral cyst, or a frayed irregular contour of that labrum, which would suggest pathology. You can do a sweep or slide across the entirety of that anterior hip joint to look for the labral pathology we just mentioned. And you can also look for any irregularities along the femoral head. And you'll note with our patient here, you'll see that bump along the femoral head, which correlates with the cam deformity we saw on x-rays. And in this view, you can appreciate the iliopsoas overlying the hip joint. So dynamic assessment of the hip joint can be performed for hip impingement in a coronal oblique plane along the anterior lateral hip joint. You can put the hip inflection in adduction with dynamic assessment of putting that hip from neutral into full internal rotation. This can be a pretty difficult maneuver as typically at least 90 degrees of hip flexion is needed to cause hip impingement, leaving not a whole lot of room for the probe. So if you do the approach where you're keeping that probe a little bit more lateral, it sometimes can be helpful. In our image here, you can see the cam deformity. However, there's no sonographic evidence of impingement. Additionally, the patient had normal internal rotation, range of motion on exam, and had no pain during impingement testing. And so these findings and a lack of history of chronic hip pain suggest that the cam deformity is an incidental finding. Just medial to the hip joint, you'll see the neurovascular structures. You can take a look at the femoral nerve and femoral artery and vein. We don't tend to see a whole lot of pathology here, especially in pediatrics. We're typically identifying these structures during in procedures or injections, so we know to avoid this area. But you can put on Doppler and also do compression to make sure that vein, femoral vein compresses. You're not dealing with a clot. So with the hip in neutral or slight external rotation, you can slide laterally and just slightly superiorly away from the neurovascular structures in the hip joint to take a look at the iliopsoas tendon. And this, you'll have your transducer in more of an oblique axis. The iliacus and psoas major muscles will merge together to create the common iliopsoas tendon, which we see in our current view. With the iliopsoas, it's important to note that there can be a good amount of variability in the appearance of this muscle and tendon. Some examples of this, you could have a bifid iliopsoas tendon. You could have accessory slips of either the psoas major or the iliacus muscle, or some people might just have some attachment of the muscle directly to the bone. Here you will see the hyperechoic tendon resting above the brim of the pelvis with medial fibers of the iliacus just adjacent to the tendon, and those lateral fibers are out more laterally. And on the far lateral aspect of the pelvis, you can see some cortical irregularity, which is getting into the AIIS apophysis. And then that pubis is seen more along the far medial aspect of the pelvis. Overlying the pubis is the psoas muscle with the neurovascular structures we already took a look at, located a more superficial. That femoral nerve is a little difficult to visualize in this view. It's not perfect, but you can see somewhat of a honeycomb appearance with artery just medial to it. That vein is likely compressed by the overlying ultrasound probe or just out of the field of view. And so that iliopsoas tendon should be checked for the presence of any bursal distension or inflammation. If there is bursal distension, it's typically going to be deep to the tendon, underneath it along the brim of the pelvis, and it can extend medially. This seems to be a pretty uncommon finding, even in the setting of internal snapping hip syndrome. However, it's important to note that the iliopsoas bursa can communicate directly with the hip joint in upwards of about 10 to 15% of the population. So it's important to keep in mind that pathology in the hip joint could cause an effusion and leak over into the iliopsoas bursa for some individuals. And this bursa is the target for diagnostic or therapeutic injections for snapping hip syndrome. In our patient, there's no obvious bursal distension of the iliopsoas tendon, and the tendon itself has normal echogenicity. You can check the tendon in the orthogonal long axis view, where you will see a nice fibrillar structure passing over the femoral head with normal echogenicity. You could follow that tendon all the way down to the lesser troch of the femur to look for any pathology. And I'll say that the lesser troch is an important area to assess, as you can get apophyseal avulsion fractures here in kids. It's similar mechanism as you would with like an ASIS apophyseal avulsion. You can have like a sudden forceful contraction of the iliopsoas, a sprinter coming off the blocks, or like our patient here, a soccer player with a sudden kick and feeling a pop and pain along the hip. So take a look at this insertion site along the lesser troch. You can turn the probe 90 degrees and drop the probe down to the all the way down to the lesser troch. We switched to the curvilinear probe here for our patient to better see it, as this is a little bit more of a deep structure. And we put that patient in more of a frog leg position to give us better access to the medial thigh. In that image there, you can note there's a decent amount of anisotropy along the tendon attachment, but overall, this is normal in appearance, and there's no evidence of apophyseal avulsion at the lesser trochanter. All right, and so here's dynamic assessment of the iliopsoas tendon along the pelvic brim or iliopectineal eminence. To assess this, you want to get that hip in a favor position, and then you can, it's almost like a circumduction motion, but you can extend and internally rotate the hip to see if there's an abrupt movement or snapping of that tendon as the medial fibers of the iliacus move out of the way as it returns back to its neutral position in the pelvis. A lot of times that snapping is due to those medial fibers of the iliacus getting interposed between tendon and bone. However, there could be something else going on, like those individuals who have a bifid iliopsoas tendon, they could be snapping over one another. There's some evidence to suggest that upwards of 40% of people will have asymptomatic snapping on ultrasound. With our patient, there's no abrupt snapping of the iliopsoas tendon as it moves medially and inferiorly back to the pelvic brim with leg extension and internal rotation. Although I will say he did have some pain along his ASIS when getting into that full Faber position. So after assessing the iliopsoas, we're going to just slide that probe laterally to assess the anterior inferior iliac spine. In the short axis view, you will see the hyperechoic direct head of the rectus femoris overlying its attachment to the hypoechoic, or I should say more anechoic, AIS apophysis. In this short axis view, you'll see the iliacus medially and sartorius laterally, with the glute med just deep or posterior to the sartorius. As we move proximal to distal in the video shown, you'll see a hypoechoic area just lateral to the direct head of the rectus, which is the indirect or reflected head of the rectus femoris. The direct head of the rectus femoris can be visualized in both short and long axis at its origin site along the AIIS and follow distally to look for any pathology. The apophysis can be assessed for any increased or asymmetric cortical irregularity, displaced osseous fragments, or asymmetric hyperemia to suggest apophysitis or an acute avulsion injury. I'll say that hyperemia can be pretty difficult to assess, given that it can be normal to have some degree of hyperemia along an apophysis in a kid. So if you're concerned about a particular apophysis, it's always a good idea to compare it to the contralateral side and look for any asymmetry. So here's that orthogonal long axis view of the direct head of the rectus. It shows a nice fibrillar structure attaching to that AIIS without any abnormal echogenicity or significant cortical irregularity. And additionally, on Doppler assessment, there's no hyperemia appreciated. In this view, you can see that dark spot just below the rectus, and that's where you're starting to see that indirect head with a good amount of anisotropy. All right, and then to take a look at the indirect head, this can be a pretty difficult structure to visualize. One technique you can use is starting in the short axis along the AIS and sliding proximally until you see that shadow. And then you'll slide that transducer a little lateral and rotate it so you're more of an axial oblique plane. In our patient, you can see a nice clearly defined fibrillar indirect head of the rectus without any abnormal echogenicity. All right, we're going to move up a little bit now to the anterior superior iliac spine, which is where the key pathology is in our case. And so you're going to move superiorly away from that AIIS and switch over to a long axis view along the lateral aspect of the ASIS apophysis. In our image, we can see that apophysis, which has obvious cortical irregularity. There also appears to be an avulsed osseous fragment labeled by that orange arrow. You can see an anechoic, hypoechoic anechoic area immediately above and below that osseous fragment, which could indicate cartilage. So you could be dealing with a minimally displaced osteal chondral fragment, which can occur with apophyseal injuries. Alternatively, that hypoechoic area could represent a small hematoma or a fluid collection. And additionally, there does appear to be some hypoechogenicity and loss of fibrillar structure along that proximal TFL tendon as it inserts onto the apophysis, which can indicate potential tendinous injury. Fibers of the glute med muscle are seen deep to the TFL tendon. When adding on power Doppler to this view, you'll notice hyperemia along that area of cortical irregularity and that avulsed fragment. As mentioned previously, it's difficult to really interpret isolated hyperemia and apophysis, as there can be an expected physiologic amount on power Doppler. So to help with this interpretation, you can compare to the other side. And here you can see that distinct difference between each ASIS apophysis. So the apophysis along the left hip on the left side of the screen has a smoother contour with minimal cortical irregularity. Also, you're not seeing any signal on power Doppler. This is in contrast to the right hip where you see a lot of fragmentation of the apophysis with an avulsed fragment and surrounding hyperemia, which is indicative of an acute non-displaced or minimally displaced apophyseal avulsion fracture. I will say it's important to perform a dynamic assessment when evaluating a suspected apophyseal avulsion to look for stability of that fragment. In our patient, we did do a dynamic exam with resisted hip flexion that didn't show any movement of the avulsed fragment, but unfortunately, we didn't save a video of that assessment. You could tailor that dynamic assessment for whichever apophysis you're trying to look at. So, for example, the AIIS apophysis, in addition to resisted hip flexion, you could do resisted knee extension to look for stability of that fragment. In our transverse axis orthogonal view, we'll start at the ASIS and move inferiorly. As you do this, you'll see that TFL tendon and muscle to the lateral side or left of the screen, and the sartorius tendon more to the superior medial aspect. Way further medial is the iliacus muscle. It's difficult to appreciate in this view. However, there's questionable hypoechogenicity and slight loss of fibrillar pattern, the TFL tendon, as it's attaching laterally along the ASIS, as we saw in our other view. We didn't save a video here, but you could follow the sartorius all the way down to the anterior medial thigh and the TFL down the lateral thigh as it connects to the IT band. The lateral femoral cutaneous nerve is listed as an optional structure in the protocol. However, it's typically seen between the sartorius and TFL. It's pretty difficult to see the structure in the above video as it cuts off before going distally, but you would look at that fascial plane in between the sartorius and TFL in that bottom image as you continue to move inferiorly away from the ASIS. That still frame to the right side of the slide, I think, is a pretty key view in our case here. But it's showing that avulsed fragment along the lateral aspect of the ASIS where that TFL is attaching. And then this is the last structure we're going to include here. And again, this is getting into more of that anterolateral aspect of the hip. We'll take a look at the iliac crest. And so that left image on the screen is showing the medial structures that attach to the iliac crest, including the external obliques most superficial, followed by the internal oblique just below. And you can kind of make out a sliver of the transversus abdominis at the deepest point. You can assess this with power Doppler to look for any out of proportion hyperemia or asymmetric hyperemia. Again, you can always compare to the other side. The patient was not tender on sonopalpation when you're getting more into the iliac crest compared to anterior along that ASIS. And that right image shows the glute medius, which is more lateral and inferior to the iliac crest. All right. And so with that, we can get into our diagnostic ultrasound report. There's a lot on here, so I'll just hit the high points. And so as a reminder, we used a combination of the linear and curvilinear probe for our exam today. We were able to see a lot of our structures with the linear probe since we're dealing with a pretty thin adolescent male. However, we did use the curvilinear for a few structures in addition to that lesser troch along that more medial thigh. With the hip joint itself, there was no identifiable pathology other than the incidental cam deformity. The neurovascular structure is just medial, also or normal appearance. That iliopsoas tendon didn't have any evidence of bursitis or other abnormality, and there was no evidence of internal snapping hip on dynamic assessment. And then the rectus femoris along the anterior inferior iliac spine apophysis, the tendon itself, the apophysis was actually difficult to visualize on ultrasound, but that all looked within normal limits. And the sartorius tendon was intact along the ASIS with no abnormal echogenicity. However, getting into more the lateral aspect of the ASIS is where we are seeing our pathology today. Where there was some mild abnormal hypoechogenicity within the proximal TFL tendon and that of small non-displaced or minimally displaced avulsion fragment with hyperemia and power Doppler. The iliac crest was normal in appearance. So overall, our impression was a small non-displaced or minimally displaced ASIS avulsion fracture. And I think the last thing I'll mention is I'll comment on it can be pretty difficult at times to determine if you're dealing with an apophysitis versus a non-displaced or minimally displaced pelvic avulsion fracture. So it's really typically takes piecing together the history, exam, and imaging, integrating it together to come up with a diagnosis. So in our patient, given his acute mechanism with a reported pop and immediate pain, with that, it was somewhat subtle, but I would say actually pretty noticeable avulsed fragment on ultrasound with relative hyperemia. We were able to make that diagnosis of an avulsion fracture. And that's all I got today. I'm happy to field any questions.
All right. Well, thank you so much, Colton. That was a awesome presentation, especially just highlighting the utility of ultrasound, obviously for pediatric patients and pediatric, conditions, and just demonstrating, how valuable, it can be. Obviously, it's, easy to use for these pediatric, patients in clinic. From my experience, they usually, take, very well to doing the ultrasound, evaluation, are interested in it just because they're involved with it. And then, as you had mentioned, just, comparative to some of the other imaging modalities, other things that you can easily do, contralateral comparison, you can be doing dynamic maneuvers, which of course, for these avulsion injuries, can be helpful to see, if there's any gapping, at that area. And then, of course, you had mentioned even some of the vascular, capabilities for looking at, hyperemia, at that area. So, thanks again for that. One question that I had, you were kind of alluding to at the end, for the apophysitis versus avulsion fracture.
Uh,
I guess as far as then trying to differentiate that on ultrasound for treatment wise, do you feel like there's a major change in management than if you do pick up on an avulsion versus apophysitis, or you're kind of typically still treating it the same?
yeah, it's a really good question. It can be, I would say it provides some good prognostic value. If you're dealing with more of an apophysitis without an avulsion, I would expect that athlete to get feeling better more quickly with a period of rest. Um, and maybe they can get back a little bit sooner. Whereas if you're dealing with more of an avulsion, especially even if it's like minimally displaced or you're seeing instability on dynamic assessment, you know that it's probably going to take a while longer. And if this patient was, I mean, he was moving pretty good, just walking, but If he was having difficulty with just walking, then you're thinking if it's an avulsion, probably put him on crutches for a brief period, maybe rest him a little longer, and then rehab him. So I think it can provide some good prognostic value, and also can kind of help you with when you want to follow up with a patient in clinic.
Can I dovetail that question? This is Doug Hoffman. Colton, by the way, great presentation.
Thank you.
Just to extend on Stephen's question, we often will augment our management of muscle injury with some follow-up ultrasound studies. And of course, this apophysis will always look abnormal after the injury, even once it's healed. And this is a minor injury, and I think, management is pretty straightforward. But do you see or have had any experience with follow-up ultrasound studies with apophyseal injuries to augment the clinical management of this?
Yeah, I've had a little bit of it. I will say I haven't had a lot so far in fellowship, but sometimes it can be helpful if you have a patient with just lingering pain. I think, the X-ray on our patient here, you couldn't even see like the avulsed fragment or like a radiographic open ASIS apophysis. But with ultrasound itself, if you have like an athlete that's rested for a while, they try to get back to activity, they're still having issues. I mean, taking a look at it, and especially the dynamic assessment, if you know that there's like that fragment is moving and they're having pain and they've undergone rest and rehab, I don't at that point, if you have that ultrasound finding, it's kind of supportive. And then you can talk, if it ever gets to the point, talking with like a surgeon, they're probably not going to want to do anything about it. But talking with them like, hey, I got, persistent pain, chronic pain in this athlete for a apophyseal avulsion. There's instability in the fragment on dynamic ultrasound assessment. What do you think? But I haven't had a whole lot of it so far, but it can provide some helpful information when you're piecing it all together, that repeat exam, repeat sonogram, and then how they're doing with their history.
Hmm. Stephen or Drew, have you ever looked at some follow-up studies with these and found it useful?
Yeah, I mean, I've just had more experience with the knee more than the hip, and it's been for more of like apophysitis, like if we're looking at like Cindy Larson Johansson or Osgood Schlatters. And I think in my experience, it's one of those tricky things, kind of almost like, hamstring injuries as well too. I think the imaging is going to look worse for a lot longer than the patient's going to feel. And so I've definitely done repeat studies a lot of the time, when patients are really looking for it, but I really do try to caution them as well too, that, hey, this is going to maybe take a little bit longer, to look more, normal again. Just because then sometimes, with our athletes, especially, or, the parents, especially for pediatric patients, they get disappointed, that it doesn't look normal again. And I think just trying to caution them, the most important thing in this scenario, though, of course, is going to be, your clinical symptoms and then how you're progressing through, your exercise and rehab protocol, in that scenario. So.
This is Drew. Nice job, Colton. And I think, yeah, I don't routinely always follow these apophyseal injuries with repeat ultrasounds, but I think when you do, the one thing that I've found helpful is the Doppler. So you can hopefully see that Doppler flow decrease, and that should go along with the clinical improvement as well. But just like Stephen said, I think a lot of times these will look abnormal and sometimes worse than the patient feels. So you got to be a little careful interpreting those follow-up scans. But I think in like this case, I would definitely follow it up because I think you can potentially see some healing of that avulsion fragment over time too, which would be reassuring. So yeah, I think there's some utility in it. We don't know all the details about it, but I think it can be helpful.
All right. Don't see any other questions or comments. So that will conclude today's ultrasound case series presentation, and this will actually then conclude for the year for the fellow presentations for the AMSSM ultrasound case series presentation. So once again, thank you to all the sports medicine fellows for contributing and presenting and being involved with this. We really appreciate it. Logistically, we're going to be then starting the faculty and attending presentations at the end of July, and then that will be then running through December. So if anyone's interested in presenting, just send out an email to Derek Stokes. But once again, thank you, Colton, for the presentation today.
Thanks for having me.